Welcome, everybody. I would invite Dr. Jignesh Daswala to open the meeting. Sir, unmute yourself.
Very good evening, all the MOS members and the ophthalmic fraternity, and also the BOA members. We are having a combined journal club meet between the MOS and the BOA. We are kind enough to have expert faculties with us, Dr. Meenakshi Swaminathan ma'am, Dr. Virendra Sachdev, and an international faculty and a good friend of mine, Dr. Samira Irfan. She is all the pediatric ophthalmologists and interest into the pediatric part. We have a very interesting listing paper which is going to be read by Dr. Anisha Trivedi, and to coordinate we have Dr. Priyanka Chaudhary, and we have our the chief advisor Dr. TP Lahane sir also with us. So it's going to be an interesting session. I now hand over the proceedings to Dr. Vaishal Kenya for the
Thank
further,
you.
All the best,
thank you,
everybody.
Sir. Yeah, thank you, sir. And this is an interesting journal club meeting which deals with a topic of amblyopia, which is of relevance to all. And today we have a star of faculty and international fame, Dr. Samira Irfan, Dr. Virendra Sachdev, and Swaminathan madam. And it would be really interesting. Without wasting much time, I invite Anisha Trivedi to present her presentation.
Yes, I'll share my screen.
Yeah, please do.
So is my screen visible?
Very much.
I'll start. Good evening, everybody. Thank you for this opportunity to present at the MOS BOA Journal Club for the month of June. I'll be presenting the article Comparison of the Effectiveness of Amblyopia Treatment with Eyepatch and Binocular Occlu-tab for the Same Treatment Duration by Tomoya Handa, Hansa Thakkar, Neenu Ramakrishna et al. In the May 2022 Indian Journal of Ophthalmology, issue 70 and volume 5. Moderators are Dr. Meenakshi Swaminathan and Dr. Virendra Sachdev, statistical experts Dr. Sabyasachi Sen Gupta, Dr. Maninder Sethia, and the coordinators are Dr. Priyanka Chaudhary and Dr. Parul Deshpande. The aim of the article is to compare the conventional eye patch with Occlu-tab, a binocular open-type amblyopia training device, and to evaluate their effectiveness in amblyopia treatment. Introduction. Amblyopia is a form of neurodevelopmental disorder of the visual cortex and the visual pathway. The definition varies, but it is generally defined as decreased visual acuity in the absence of any explicable pathological or structural ocular defects. It occurs in approximately 1 to 5% of children. It impairs the development of visual function, and severe cases can interfere with school and social life. Many children with amblyopia receive occlusion therapy, that is the eye patch treatment, the gold standard treatment modality for amblyopia. However, one of the pitfalls of treating amblyopia with an eye patch is low treatment compliance due to two reasons: non-psychosocial causes, which are age of treatment and severity of amblyopia, and psychosocial causes, that is lack of knowledge about amblyopia and treatment, stress and lack of motivation. Due to these issues, a new game-based amblyopia treatment has been reported in recent years, in which better compliance can be expected in pediatric patients capable of playing games than with eye patch treatment. Occlu-tab. It is a method and device used for amblyopia treatment involving the use of open binoculars with a modified common tablet device. It has three key functions. The widescreen technology eliminates the side effects of conventional eye patches and enhances stimulation of the visual field by selectively presenting images to one eye while both eyes are open. It automatically records the actual treatment time, and this accurately evaluates the treatment duration. Provides game therapy by using a palm-sized block called the Tangy block. In a study by Iwata et al., it is said that the addition of Occlu-tab treatment to refractive correction resulted in a significant improvement in visual acuity compared to that by wearing glasses alone. Methods were: it is a randomized controlled clinical trial. Inclusion criteria: patients who presented to the hospital for the first time and were diagnosed with anisometropic amblyopia, refractive difference in both eyes of more than 2 diopters, highest visual acuity of the amblyopic eye being less than 0.1 logmar using Snellen's chart. 3 to 12 years old, Visited the clinic 3 times a week for 8 weeks after the start of amblyopia treatment. Exclusion criteria were history of amblyopia treatment, diagnosed with strabismus, difficulty in completing the visual acuity or refraction, and receiving occlusion therapy using an eye patch. Occlu-tab. Occlu-tab presents target images on an invisible tablet terminal to only the amblyopic eye with a binocular open view. The invisible display has a quarter wave plate marked on a polarizing film layer, which is altered by a linear polarization filter on the LCD screen. The output image of Occlu-tab cannot be seen by the naked eye because humans cannot natively perceive polarization. However, it is possible to see an image on the invisible display through a polarization filter. The amblyoptic eye can see the original image through a circular polarization filter even if the tablet is rotated or the patient tilts their head. In contrast, the healthy eye cannot see the original image because a light reduction filter is applied. The optical density of the light reduction filter and polarization filter are the same. These are the games which are included in the Occlu-tab. The 8 games are designed to encourage quick and approximate eye-hand coordination with horizontal and vertical eye movements. Occlu-tab has the advantage of being portable, full-color, touchscreen based, and user-friendly with a tangible block for eye-hand coordination. In the study, 40 children diagnosed with an isometropic amblyopia were recruited. All patients wore complete correction glasses fitted with cycloplegic refraction. 20 patients were treated for amblyopia with an eye patch, whereas the other 20 patients were treated with Occlu-tab. Both the group of patients were instructed to visit the eye clinic 3 days a week and to train for 60 minutes during each visit. Statistical analysis. One-way repeated measures analysis of variance, that is one-way RM ANOVA, and Tukey's tests were used to compare visual acuity before and after treatment with the eye patch and Occlu-tab. The t-test was used to compare the improvement in visual acuity between the eye patch treatment group and the Occlu-tab treatment group. P less than 0.05 was considered statistically significant. Statistical analysis was performed using sigma plot. Results: both the eye patch and Occlu-tab treatment exhibited improved visual acuity after treatment. The improvements in the best corrected visual acuity of the eye patch and Occlu-tab treatment groups were 0.16 plus or minus 0.17 and 0.33 plus or minus 0.25 logmar after 8 weeks of treatment, respectively. There is a statistically significant increase in the improvement of best corrected visual acuity in the Occlu-tab treatment group after 8 weeks of treatment. This is a graph showing the improvement in visual acuity across 8 weeks of amblyopia treatment with an eye patch and an Occlu-tab. White bars indicate the improvement in the best corrected visual acuities with eye patch treatment, and the filled black bars indicate the improvement in the best corrected visual acuity with Occlu-tab. Improvement in best corrected visual acuity significantly differed between the eye patch and Occlu-tab groups after 8 weeks of treatment. That is, P is equal to 0.02 by t-test. The discussion. In the present study, amblyopia treatment using Occlu-tab resulted in better improvement in visual acuity than that with treatment using an eye patch. Although amblyopia training time was limited to only 3 hours per week, a visual acuity improvement of 0.3 logmar was observed at 8 weeks, which was significantly greater than that observed with an eye patch. Compliance with the amblyopia treatment was 100% for both treatment modalities. Therefore, the difference in visual acuity improvement between the Occlu-tab and the eye patch group in this study was due to the type of treatment and not due to the difference in treatment duration. Conventional eye patch treatment physically blocks the healthy eye to force the use of the amblyopic eye. In contrast, although Occlu-tab is a treatment method in which only the amblyopic eye is forced to use despite both eyes being open, the frame and operation blocks of the tablet, which do not show the image, are seen by both eyes and the peripheral fused image is maintained. Amblyopia is considered to involve strong cortical inhibition in the visual cortex and a blockage of neural connection from the amblyopic eye. Therefore, it is desirable to increase the level of activity in the visual cortex. Indeed, during game training with Occlu-tab, the bilateral activity of the occipital lobe of the visual cortex has been found to be significantly greater than that observed with single-eye occlusion. The most important aspect of the critical period of visual cortex development is the massive increase in neural connections during early infancy. These neural connections constantly change throughout early childhood, leading to the formations of correct connections and inhibits ions if incorrect connections. Whether a neural connection remains intact or is suppressed depends on whether the connection is used. The basic principle of amblyopia treatment involves forcing the eye of neural connections associated with the amblyopic eye. The variety, intensity, and type of visual stimuli are especially important for brain development in children. In the present study, there was no age difference between the Occlu-tab and eyepatch groups, and the treatment duration and treatment environment were the same in both groups. There is a previous report of cognitive improvement with the use of games. However, the mechanism underlying the effect of games on cognitive improvement remains unclear. In contrast, the Occlu-tab training game seems to contribute to the development of children's attention and cognition through the combined sensory stimulation of observed body coordination. Rehabilitation using video games is an innovative tool that can increase motivation in pediatric patients. The detection of amblyopia is likely to be delayed if there is insufficient ophthalmic examinations in childhood. When treating amblyopia after the general critical period, it is optimal to choose a method that is highly effective, has no side effects, and does not interfere with social life such as school. The eyepatch method of occluding healthy eyes must be reconsidered in terms of the target age, effectiveness, and side effects. A major problem with eyepatch treatment is poor adherence. Long and intensive eyepatch training is more likely to result in lower compliance in school-age children than in preschool children due to psychosocial problems. The possibility of amblyopia training using video games, monocular and dioptic was recently reported. In children capable of playing the games, compliance with amblyopia treatment with such binocular games is better than amblyopia treatment with an eye patch. In a Japanese study, children of 3 to 9 years old, compliance is significantly higher in the Occlu-tab treatment group than that in the eye patch treatment group after 3 months of treatment. In addition, compliance in the Occlu-tab treatment group ranged from 68% to 72% throughout the entire treatment period. Therefore, we believe that game-based treatment methods are effective in maintaining high treatment compliance in pediatric amblyopia treatment. The current study involving training for only 3 hours per week in visiting the eye clinic, thus the effect of home training for approximately 4 hours daily in addition to training of visiting the eye clinic 3 times a week remains unknown. In addition, the study was limited to the treatment of anisometropic amblyopia, thus the effects of treatment on strabismic amblyopia or any other forms of amblyopia remains unknown. Further studies should consider strabismic amblyopia and other forms of amblyopia. Overall, our results indicate that Occlu-tab amblyopia training in Indian children was beneficial. However, to support worldwide dissemination of this approach, it will be necessary to analyze the effects of different types of games and clarify possible cultural and religion-related issues. Nevertheless, Occlu-tab treatment can become a viable option for pediatric amblyopia treatment in both developed and developing countries. In conclusion, amblyopia treatment using Occlu-tab resulted in a better improvement in visual acuity than that with the eye patch treatment for the same treatment duration. Further studies will determine whether Occlu-tab can become the generally preferred treatment option for pediatric amblyopia. Now I'll be presenting the MARI format for the article. MARI, which stands for Method, Assignment, Assessment, Results, Interpretation, and Extrapolation. So the method of the article was study hypothesis was well defined, study population was well defined, inclusion and exclusion criteria were also well defined, sample size was adequate, assuming 10% dropout rate, and the study period was well defined. The assignment: process randomization with Microsoft Excel with 2-size block. Patients with previous amblyopia treatment are excluded to avoid confounding. The assessment: measures of outcome addresses the study's question. They are accurate and precise. Based on only 1 hour of patching, 3 days a week, doesn't consider 4 hours of daily patching. The results: statistical tests used were appropriate. 1-day RM ANOVA and Tukey's test was used. Interpretation: both treatment strategies led to improvement in visual acuity with no harm. And the extrapolation: studies extrapolated to pediatric patients with anisometropic amblyopia. It needs further studies for generalized treatment to for all forms of pediatric amblyopia. Thank you.
Thank you, Anisha, for a very wonderful presentation, a very crisp presentation.
Thank you, ma'am.
With this, before we really go on to the discussion about the article, I would just like Mr. Oliulla to give us a short information about the binocular dioptic vision therapy. So, for all of those who don't know who's Oliulla, he is the founder of Binox Vision Therapy, and he has done his formal training from George College of Optometry, and then he's done his formal fellowship training from L.V. Prasad Eye Institute. And his interests include basically the binocular vision and vision therapy. So with this, I would just hand over to Oliulla. Oli, are you there? So can you just share your screen? Yeah.
Very good evening. Thank you, Dr. Parul, for having me here, and sincere gratitude to MOS and BOA for giving this opportunity to present on vision therapy in amblyopia. So as Dr. Anisha spoke about a binocular approach, so it made my presentation a lot more easy. So I'll take you through a quick presentation on present landscape in managing amblyopia in pediatrics and adults. So today, this session aims to give you a real-time expected outcomes in binocular approach in all form of amblyopia, especially in pediatric and adult age group. Before I go into detail talking about binocular approach, a little bit of neurosciences just to give you overview how different approach of treatment works. So as you know, in amblyopia, there are no issues with the primary and primary neurons which are there in the eye, and usually it starts affecting the lateral geniculate body level and visual cortex level. So let's see what happens on those areas. So as I mentioned that primary neurons, which are first, second, third order neurons, are completely normal in amblyopia. However, the problems start getting in the fourth order, lateral geniculate body, and in the Broadband area 17. So if you have an early deprivation, especially you get these cells are pale and shrunken in the LGB, and then if you just remove the stimulus deprivation, then the auto regeneration do not happen until unless you cover the dominant eye, and that's why it is very effective if you patch the good eye at that plasticity period, which Dr. Anisha again explained. Now, if you look at the other component, especially in the Broadman area 17.4C, it is more of marked shrinkage in the input stripe. So it is predominantly in the ocular dominance columns which are getting affected. So one of the eye takes over the area of the non-deprived eye. So non-deprived eye takes over the area of the deprived eye, and that results into the density of amblyopia. And again, as Dr. Anisha explained about why do we need a newer management, all of us know that with the traditional penalization or patching, we have certain limitations, and those are not limited to those followings, which are going to be there on the next couple of slides. So we face a major issue with the residual amblyopia in all successful treatment group. This is a meta-analysis which is available, still shows around 2 logMAR lines visual acuity deficit in all patients. Same time, the compliance is always an issue. So if the child becomes more than 5 years old, then it becomes more challenge to adhere them into the treatment protocol, and is reported to have very limited efficacy in terms of the compliance to little older age group. And the improvement takes long time, is prolonged, and the fastest reported is though 4.8 lines in 4 months of 6 hours a day patching. And then in adults, there are studies which are available, but it is very, very limited to yield certain results. And most of the participants who showed improvement, the moment you stop patching, again regress back. So if adult, in spite of getting improvement with monocular approach, once you stop treatment, it goes down. So all the efforts goes into vain. Now, apart from this, we never looked at what happens to the time of after we stop the recurrence and to their binocular vision levels like fusion, stereopsis, what about their eye-to-hand coordination and oculomotor deficits like circuit perceivable. And these are all aspects leads to think about, okay, let's think amblyopia and more into binocular way, try to address them in the binocular way so that we can address lot more issues associated with amblyopia. And it started long back. So with a very simple concept called monocular fixation in binocular field, what actually it does that when you have a background with the binocular environment, but you can assign tasks which are specific to the amblyopic eye and the dominant eye, that terms as monocular fixation in a binocular field. So given an example with this simple example of playing cards, if you just put a color to it and then you put red-green glasses, which is available in the clinic, the moment you close one of the eyes, so suppose you close your green filter and then you start seeing, okay, one of the slide is missing. You do not see one of the card because the red filter light is striking off the red colored those component, and opposite happens to the other eye. The moment you cover the red filter and then you do not see that component. So when the patient, especially in the adult patient, just to simulate how it works. So when somebody is keeping both the eyes open, they do not know what actually happening, but they still use both the eyes together to play or to see the cards, playing cards. So based on this concept of monocular fixation in binocular field, we can give lot of exercises for the patient while you are calling them in clinic or home based. Let's see a couple of them. So it's as simple as drawing, writing, reading, or you can ask them to use this red green filter and use the felt tip pen with different color, red and green or red blue, and that makes this MFDF concept very successful. Moving forward, you have a lot of games available. So this is one of the hard chart you can just cover with the particular filter and then see through it. One of the eye will be seeing, another eye will not see the target. That it is so simple to simulate in the clinic or home environment. So based on this concept, there are many Android and iStore games which are developed in recent times. So these are few Android games like Stereo Blocks, Lazy Eye Blocks from LeoVision. You must be familiar with this. I'm sure many of us given this exercise at home for the patient. However, the problem with these games is the saturation level adjustment becomes difficult. And as the patient is doing directly on their own, so you do not know what kind of contrast adjustment they are doing and whether it's going to be effective or not. So that limits is efficacy. So these are many of those games which are available even in the Apple stores. Now, moving forward with this concept, lot more newer technologies are coming. As Dr. Anisha spoke about this recent article from Somaya that it gives results, quick results. Like in 8 weeks time, you do get 3 lines of visual acuity improvement. But what this concept were more about some alternative to patching, where you are just bleaching out the dominant eye by giving a white screen, whereas the other eye is actually doing the activities. So it's not a complete binocular approach, somewhat a partial, because you are still keeping some stimulus to the dominant eye, unlike in patching where you are completely taking off the stimulus from the dominant eye. Now, development of stereopsis could be difficult with this. However, if you look at the results or the simulation of the game, because of the Polaroid filter, it filters out the component and only the amblyopic eye see this task. And with those 40 patients outcome, as Dr. Anisha already clearly explained about it, do show around 3 lines of visual acuity improvement, which is encouraging. And the amount of improvement is happening is only because the
only if you could sum up, please.
Sure. Compliance levels go down. Then we have something from Cure side. It is again the similar concept, having different short video of it. I'm skipping those. But if you look at the visual acuity improvement over a 24 weeks is around 3 to 4 lines again. Now there are components like we also have Binocs into it, which is a dioptic base. Again, what we are doing is giving a contrast adjusted image, especially to the dominant eye. The moment we reduce this dominant eye contrast, brain suddenly starts seeing them binocularly. And based on this concept, because the inhibitory interaction in the visual cortex goes down, when you can adjust the contrast, then patient starts seeing. This article, just a couple of hours back, we got it published with 161 patient data, which shows around 4 logMAR lines improvement over a period of only 6 weeks. Along with it, the kind of stereopsis somebody gains is enormous. To start with, we had around 65% patient as stereopsis, especially more into an asymmetric age group. But end of the treatment, 90%, almost 90%, as you see, they improved or gained their stereopsis. These are very unique cases in adult amblyopia that you can manage, like somebody coming for LASIK at 24 years with high anisometropia.
Oli, unfortunately, we're running short of time. I would like you to sum up with the last slide, please.
Sure, one couple of more. So this case, and then into even post-cataract surgery amblyopic patient. And so these are advantages where the compliance is more with dioptic therapies and the improvement is very fast. It can restore binocular vision and effective in older age group. However, there are certain demerits to it, that it can work only in aligned eyes. So it needs to be, patient needs to be motor aligned to enroll for any binocular approach. And if there are microstrabismus or eccentric fixation, the outcome is going to be poor. Thank you for having me here once again.
Thanks, Mr. Oli, for this wonderful eye-opening talk. Next, I would like to request our esteemed panelists to comment about today's article and give their review on the device-based therapy. Meenakshi, ma'am.
Dr. Meenakshi, are you there?
I'm here. I'm here. I had to unmute myself. Yeah. And first of all, let me thank the BOA and the MOS for this wonderful initiative, something very novel, something very academic, essential to bring the track, bring us on track, that this is knowing how to critique an article is so essential and seldom addressed in postgraduate training these days. So I congratulate you, Dr. Jignesh, on this fantastic initiative.
Thank you.
And I place on record my appreciation for including me in the Pediatric Ophthalmology Amblyopia Journal Club today. And very beautifully summed up by Dr. Anisha. I believe you're a postgraduate, and that was exceedingly good for a postgraduate to get a good grasp on how to present a Journal Club article. And also on the panel, it's wonderful to see a lot of friends and people I know. So a very good evening and thank you. So I have actually written down some of my comments, and I thought, for sake of time, I will just sort of go over those with you. So first we will, and because I'm hoping there are many postgraduates who are listening in, I want to start off by saying, when you look at an article, you first and foremost want to make sure that the methodology is sound. If everything else is secondary, if the methodology is not sound, then whatever the paper is drawing as conclusion is not acceptable. That is the bottom line. And not only that, the methodology needs to be in detail and it needs to be reproducible, so that if you want to carry out the same study in your center, you should be able to do that. So from that point of view, I would like to, especially if this is an unfamiliar technology, like what has been presented in this study. So if it has been published elsewhere or the new technology has been described elsewhere, then adequate reference is also essential with the authors give us. And I would be curious to hear from Dr. Sengupta about the statistical part of it a bit later. Now, the other wonderful thing about this journal article is that it's a nice collaborative effort where technology has been developed by a Japanese university and has been tested in several prominent Indian ophthalmology departments. So that is something to be very proud of. Now, if you really look at the larger picture, what is the need for the study? Because in the last decade or so, there has been a revival of sorts in the newer modalities, which Mr. Olila very beautifully showed in his presentation. So yes, we all know occlusion, we know penalization, this is what we've been using regularly. Then why do we need more therapies? Because as you very well know, compliance is a very big factor, especially with occlusion, and monitoring of the same, and penalization, as you know, because you put a medication in a young kid's eyes, has side effects. And also, like we have been pondering over and over again, the whole point of doing all this is to recover some binocularity, and then you go and occlude one eye, and you substantially blur the vision of one eye. Aren't you defeating what you set out to achieve? And so that is exactly why we have therapies like Binox or the Occlu-tab. Now, okay, so I'm going to jump and say, what are the good things about the study? Well, the short duration of just 8 weeks showing improvement just 3 times a week for 60 minutes with the Occlu-tab. Great. This is very promising. And particularly for this generation where games are important, that too, there are many types. There are 8 subtypes of games to keep the boredom at bay. Well, that is a great thing about the Occlu-tab. But what I was not totally happy is more detailed description, because only a purely anisometropic group has been presented, but there is no mention about the refractive error, where these anisomyopes, where these hyperopes, where they're astigmats. What was the spread of the refractive error between the 2 groups? No mention at all, and that's a huge bias in my mind. The other important thing we all know is, as pediatric ophthalmologists, we give a certain time called refractive adaptation, where no amblyopia treatment is started. We only give glasses, and we wait for 8 to 12 weeks to see whether on its own the vision will improve. In other words, there is no mention in the study if a refractive adaptation was used at all. Was there a time lag between diagnosis, start of glass, start of therapy? Nothing is mentioned. It also is not says, when was the vision checked during each visit? Was it after the Occlu-tab treatment of 60 minutes, or was it before the start of the Occlu-tab treatment? There is, again, no mention at all. Of course, this is an 8-week study, and the big challenge in amblyopia is, was the improvement sustained? No idea. And also, I felt the comparison between, you have to, as they say, compare apples with apples. You cannot compare apples with oranges. That's my main grouse with this study. How can you compare 60 minutes of occlusion 3 times a week with a game? I mean, whatever it may be. It's like comparing, you say, I know this glaucoma medication has to be used twice a day, but I am going to put it only once a day, and I'm going to compare it with another group that is once a day. That is so unfair. So I felt the proper dosing of the occlusion was not used at all in the study. And to me, that was a big no-no. And no idea about stereopsis. Isn't that what all this is about? We do keep the eyes open, use a Polaroid filter. What is the stereopsis of these children? Was never mentioned, was not studied, I believe. And anyway, it's what is the cost effective? Is it cost effective? Is it going to be suitable? Is it going to be possible in our Indian setting? No idea at all. So those are, and also there's a passing mention saying the children's attention and coordination was studied, and I have no idea how. So except for a few of these limitations, which I feel are very important to address. Otherwise, it is an elegantly done study in a promising new technology. I think that's all I have to say. And thank you once again for having me.
Quite right. Very nicely put up, ma'am.
Virender, are you there? Can we have your comments also?
Yeah.
Yeah.
Good evening, everyone, and thank you. I think Dr. Meenakshi has very well summarized most of the points. I was also very much concerned about the way they have done in the methodology. They have mentioned about it's a randomized controlled study, but the dose of patching is really different. And they have not, if you look at the average visual acuity, which is mentioned, majority of the patients will not improve with 1 hour of patching done thrice a week. So that's a big thing over there. They have not also given a distribution of the visual acuity for patients, which level of visual acuity improved. The patient's baseline visual acuity was 20/40, that improved, or the patients with visual acuity worse than 20/100 also improved. So that's another thing that they could have elaborated upon. It's a randomized control study, but they have mentioned that in the inclusion criteria, patients, it's a prospective study, right? They have mentioned that patients who came for a visit thrice a week. So that's not the language for a prospective study. It looks like it was a retrospectively done study. And another important aspect is that Occlu-tab is to be done in the office only. It's not available for the home-based therapy. So that is another limitation that somebody has to think if we are going to order this as a prescription for the amblyopia therapy. But otherwise, it's a promising therapy that we need to keep. And maybe we should look at the stereopsis outcomes also. That would be very important in this. Maybe comparing this with other binocular therapies would be another important aspect to do if somebody wants to really try these binocular therapies. Thank you.
Thank you so much. I would ask Dr. Samira Irfan to give her comments on this topic. What does she feel? Ma'am, unmute yourself.
Hi, everyone. Thank you so much for the invitation and to be a part of all these elite ophthalmologists. And I would systematically highlight some important points, which number one to me was the sample size. I think it's too small, only 40 cases, 20 in each group. The prevalence of amblyopia, which has been quoted worldwide, is 5%, 5% of the general population. And in our part of the world, there is no screening, hardly any screening. The incidence is a lot higher. So to represent a treatment therapy, which is going to influence this huge population of amblyopes, I think that the size is too small. Then another major concern to me is the age of the cases. Only age group 8 plus minus 2 years is included. Why the others are excluded? Why only they have included this age group? Is this the critical period they are worried about? Well, we all have to understand what is the critical period. It is a period in which the brain is most susceptible to amblyogenic influences. And this is the period where maximum visual development occurs. But it does not mean amblyopia ends at 6 years, or it cannot, the vision cannot be improved after the age of 6 to 8 years, or 11, or at 17, or in the 20s or 40s even. So limiting it to just 6 years, I don't think that's justifiable. And critical period, I mean, there are on the neuroplasticity, there are now hundreds of papers. And that tells us that amblyopia can be treated at any age. So the third concern is, as Dr. Meenakshi also pointed out, the period of refractive adaptation. When we first give patient glasses, about 30 to 50% of vision improves just by glasses, because the brain starts seeing clearly. And the optical system and the visual connections of the amblyopic eye, they have to be given time to develop. And we see patients regularly after giving glasses for 8 to 12 weeks. And once the improvement in vision stops with glasses alone, then the treatment is started of amblyopia. And at that time, we start grading the level of amblyopia. So this is not being mentioned at all in the study. Then exclusion criteria. Now, why previous amblyopia therapy was excluded? I mean, it's totally a myth. If amblyopia has been treated previously, the vision cannot be improved. It can be improved anytime. The other thing was strabismus. All patients with strabismus were excluded. So it's important to understand that an eye, when a baby is born, they start seeing the eyeballs are lying divergent in the orbit. Only if the eyes are seeing, they will converge. Convergence will come into action. And to see at a distance even, there is some convergence of the eyeballs. And as the object comes closer, the convergence increases. So an amblyopic eye, there is failure of convergence into the Pannon's fusion area. The vision is blurred. Why would that eye converge? So the strabismus is a part of amblyopia. No matter how small or how big the angle of deviation is, strabismus is always there. So you can't exclude strabismus patients in a study which is for amblyopic patients. The fifth point is that the treatment was instituted, as we mentioned, in clinic 3 days a week, just for 1 hour. So now there is an important phenomenon of binocular rivalry and binocular interaction in the brain, where the dominant ocular connections, they prevent the connections of the amblyopic eye to be developed. So if the therapy is being given only 3 days, what is happening in the remaining 4 days? The patient comes back in the next week. Have we said what is the vision at the start of that week? Has it regressed in that 4 days when there was no therapy? It's not mentioned. So that phenomenon is extremely important to be taken into account. And this is, I mean, very simple to understand. It's like our two hands, perfectly normal, but all our life we are using the right hand in right-handed people. And only if the one hand is fractured, say the right hand, and we start writing with the left hand without the dominance of the right hand, the left hand will be perfect in 1 to 2 months. It will start writing as good as the right hand. But if we keep on using both hands side by side, the left hand can never be as good as the right, ever. So it's as simple as that. So this has to be kept in mind in whatever therapies you design. As soon as you remove the inhibitory influence of the good eye, the bad eye ceases to develop. And that is why the improvement in these studies was only 2 to 3 lines at the most. Even in ATS studies, the improvement in vision was only 3 to 4 lines. So what about the remaining lines? I mean, you have to restore vision to 6/6, 20/20, make the vision perfect. And because the visual system is normal, as you've just seen in all the previous presentations. So why not restore sight to perfection, to 6/6? Why stop at 6/12 or 6/18? That to me is not right. And the other thing is no weaning protocol mentioned, no regression of vision in any case mentioned. Once the therapy was stopped, did any patients regressed? These are all important considerations. And then the vision is study on Snellen's, and it is plotted in the charts as logmar. Snellen's has only 7 lines with the different number of letters in each line, while logmar there are 10 lines and 5 letters in each line. How can you check the vision on one Snellen's and plot it on logmar? To me, it's totally absurd. So these are what I think the drawbacks of this study. So thank you.
Nicely pointed out. Very nicely pointed out.
Thank you so much, Ignesh.
Just a brief introduction of Dr. Samira. Dr. Samira is an international name in pediatric ophthalmology. She hails from Lahore and and very keen teacher, has got many students even on a WhatsApp group, and that is one of the WhatsApp group where I am avidly following her, and that's how I interact and know her. So thank you, ma'am, for the invite at a short notice. Thank you so much. Your inputs were really great.
Thank you for having me.
Thank you, Dr. Samira. So it's as rightly said that we stopped only with the 3 lines of visual acuity improvement, and we did not take this therapy further to improve to 6/6. So I just want to ask Dr. Virender. So is there anything else that could have been done in these children to improve the vision to 6/6? So can we add either an occlusion therapy along with the binocular, the Occlu-tab therapy, or only home occlusion also should have been added to this so that we could have a better visual improvement?
Yeah, thank you, Dr. Parul. Actually, I think the goal of the study was to describe what is the outcome at this period. So that is what they have given, but they have not given the distribution according to what is actually happening in how many patients the visual acuity has reached this level. So that is an important aspect that needs to be studied separately. Coming to the question of if there is residual amblyopia despite compliant therapy with one form or other, it's always possible that we can go ahead with the combination therapy. So we, even with conventional patching therapy, binocular therapies can be added. And in fact, these binocular therapies might work better when the visual acuity has improved to a significantly higher level, rather than starting with something like a severe amblyopia where visual acuity is 2200 or worse, or maybe 2000 or worse. So that's one point. So similarly, patching could have been added, even penalization can also be added, optical or pharmacological. So combined therapies do play a major role if the patient has this, but I think it's beyond the scope of what was described in the goals of the study. So that's why that's not mentioned. But if we have patients further on, this can be done. And in fact, they could have even increased the dose of the binocular therapy, but it all should be done in a systematic manner so that we can draw systematic conclusions.
Yeah, thank you, Dr. Virender. So can we have Dr. Sengupta telling us about the statistical part of the article?
Thanks, Dr. Parul. So I'll also talk a little bit about the clinical aspect because I'm, of course, a clinician first. So if you permit me, I'll just quickly try and share my screen. Okay, so this is a lot of things which have already been pointed out by Meenakshi ma'am, by Dr. Virender, and everyone else. And Dr. Samira's inputs were really, absolute bullseye. So I don't have to say too much. A couple of small things like, so if it's a randomized trial, that word randomized trial should be part of the title itself. When you have an author, who is from outside, and the technology is from that country, right, from Japan. So you need to definitely think about whether there are any different kinds of interests, whether any conflicts, patents, financial interests that the author might have, and so it's not right or wrong, but whether it's declared or not is something. If it's not declared, maybe you can go a little bit in the background and do it. So then when you look at the methods, again, they don't actually mention in the abstract what about the refractive correction that was given or not at the time of instituting treatment, and then this word prospective should have the word randomized following it. Again, 1 hour per day, thrice a week. This has already been discussed too many times. I think the ethics committee should not have given approval at all. So this is not at all the standard of care, isn't it? So for 8 weeks, you are depriving a child of the proper patching and occlusion and proper therapy. So I think the ethics committee should not have approved this. I don't know what the others from institutions think. Then this study uses something called repeated measures analysis. So this is the repeated measures ANOVA. And why this is being used is because you have before and after measurements at many different time intervals, right? So the same patient is having repeated measures being done at every time, right? So when you have such outcomes, we use this kind of test, which is the repeated measures ANOVA. So again, in the results, so this already again has been pointed out. What was the refractive error? What was the mean age, gender? So this is a very poorly written abstract overall. And then they directly mention the improvement. So they should essentially give what was the BCVA before and then what was it after. Then here they don't mention the word logMAR at all. So this is 0.33 plus minus 0.25. Now, if you see the standard deviation, it is almost that of the mean, isn't it? 0.33 plus or minus 0.25. And now this shows that there is a lot of variation across the mean on either side. And so this shows that this is non-parametric in distribution. And when you have the standard deviation, which is more than half the mean, here it is like 0.17, anything more than that, it is better to come out with medians with interquartile range rather than means with standard deviation. Couple of things more. So this is what Dr. Virender, I think, pointed out. He said that, the inclusion says had visited the clinic 3 times a week for 8 weeks. So this is what exactly I have seen. This cannot be an inclusion criteria for prospective study. It has to be a retrospective study, right? So there's a lot of doubt on how really this was conducted. Overall, again, the mean age was 8 years. This really should be in the results part. In the results, in the first part, they say a lot of different values, one after the other. It's just a bombardment on your senses. You can't really make out, which healthy eye, good eye, bad eye, amblyopic, this therapy, that therapy. So this should have been tabulated, essentially. Now, interesting to note, when you look at BCVAs at the different time points, in this Occlu-tab group, between 5 and 6 weeks, there is a sudden jump, isn't it? So this is all sort of going equal to each other till 5 weeks, but suddenly there is a big jump in 6 weeks, 7 weeks. So what happened here, and why this jump sudden? And this is where the actual difference is starting to happen. Now, why this happened and what is the machine doing so that this sudden jump is happening at the 6th week time point is something that I think the author should definitely probably explore more. Again, statistically significant differences in all were noted, but then it really should be looking at adjusting for baseline refractive error, like Dr. I think Virender also said, Meenakshi ma'am also said, we need to really look at adjusting for differences in refractive error between the two eyes. So did somebody with -6 and a -10 amblyopic eye respond the same way? Again, larger sample sizes were needed. Also, it may be good to report the results from myopic and hypermetropic eyes separately. So overall, so these are some of my sort of thoughts here. And if you see, the authors continuously are sort of defending themselves by saying that current study involved training for only 3 weeks, 3 hours per week. Again, they say limited to only 3 hours per week. So they are very much aware that this is a big drawback in the study. According to me, the ethics committee should definitely not approve it. And if you give me another minute, I just wanted to quickly show you how sample sizes are calculated. So this is the sentence where they say, this will be interesting for everyone. So they say the difference in visual acuity in logMAR between groups was estimated as 0.1 plus or minus 0.1 based on a previous study. And if you look at this previous study, let me just pull it out. So this is the previous study that was done. And now this is, glasses treatment and Occlu-pad treatment group. Now this glasses is without occlusion and this Occlu-pad treatment is with occlusion. So there's a huge difference here. So if these are the values which have been plugged in 0.05 plus or minus 0.09. And, these are basically the changes which happened at 6 months. So this is logMAR, right? So this is really similar to each other. And if you plug this into a statistical software package, I'll just show you how this is. So this is data. So we go into statistics and we go into power and sample size. And, this is how the interface looks like. So what is the mean in one group is 0.05 plus or minus 0.1, or that was 0.09. In the other group, the mean is 0.05 and the standard deviation is 0.1. And then, this is the power of the study. So if you just click OK, you will see the sample size is 16 per group, 16 or 17 that was actually done. However, if you look at this study at baseline, the one that I have used for sample size calculation is absolutely, it's again, this kind of study should really not be allowed at all. So, so these are some of my takes on this paper.
Thanks, Dr. Sen Gupta. Very well statistically analyzed. I want to ask Dr. Meenakshi ma'am, the next question is, ma'am, in current era of digital myopia pandemic, how to convince the parents for this device-based amblyopia therapy? Dr. Meenakshi ma'am.
Yeah, good question. Something that we are bombarded with every day is, like a chanting. We tell everybody, cut down on gadgets, cut down on gadgets. I know, but we have to look at the larger picture. In amblyopia, vis-a-vis myopia, we are looking at a short-term treatment. Whereas myopia addiction and change in lifestyle is a long-term problem. So you will have to choose, you will have to make a pact with the devil. There is no doubt about it, but we are very clear in what will be the end point. And that is why what Dr. Virender was saying, it is absolutely imperative to introduce these games, these binocular games, binocular treatments only after you have improved the vision to a certain extent with conventional treatment like occlusion that works. So that is always the first step. And when you do that, then the duration of treatment of these games becomes shorter. And these games, unlike addiction to gadgets is not endless. It's usually finite. The amount of time that the child spends on these games are all finite. And so you have to choose between myopia progression and if you have to, and using binocs or any other such games to improve, you will have to go with the short-term gain that you're looking for. And then once you have treated the amblyopia, then you shift gear and talk about myopia control. Because time is of the essence when you're treating amblyopia. You want to get the vision up fast and, like Dr. Samira was saying, as equal as possible with as best binocularity as possible. Once we achieve that, then we change the dialogue, then we change our chanting.
Thanks, madam. My next question is to Dr. Virender Sachdev, sir. Sir, compared to patching, which is monocular amblyopia therapy, can we use this device-based therapy for binocular amblyopia or strabismic or adult amblyopia?
Thank you so much for the question. Well, I think the study cannot answer this, but at the same time, I think it is possibly the need of our that binocular therapies are studied for amyotrophic amblyopia, especially because there is no other definite way we can improve it. Patching and penalization are out of the question when it is binocular amblyopia, such as bilateral amyotrophic amblyopia. In fact, Oli will remember our discussions where we have been trying to, try to study binocs where it might be useful for amyotrophic amblyopia and see the outcomes. So over there, definitely it is there. As regards strabismic amblyopia, further definite well-planned study would be very helpful, and we should explore such studies.
Dr. Virender, I have seen people giving alternate patching. So is it, that is what we look at as a binocular amblyopia with alternate patching? I mean, is it?
It is not effective as a therapy. In fact, Shankar Netrala did a very big study, I think many years ago, where they tried to find out whether it was effective, and it was not useful. We have all tried it to a small extent, but it is not really effective. So we don't encourage alternate eye patching for amyotrophic amblyopia anymore.
So what protocols?
If I may just say something, one shouldn't do something just because we don't have anything else to do, anything else to offer. It has to be scientifically based. Because what if during your patching or something for amyotrophic amblyopia, there is an onset of strabismus. Sometimes, occlusion can actually create a strabismus. So if you do something that is not scientific, that has no evidence, and you create a problem, you land up in a lawsuit, you land up in court. So I know your hands are itching. What do you have to offer? Nothing else but glasses. You want to really do something for this patient. But unfortunately, we still don't have that evidence. But like Virender said, maybe binocs is actually a very good thought. Something to.
And what about the adult amblyopia, ma'am?
What is it?
Amblyopia, the therapy, the tab-based therapy for adult amblyopia.
I don't think we have enough results. Again, we need. The problem is it's a very mixed group that you don't get the numbers in adult amblyopia. It's a smaller sample, and it's a very mixed group with different refractive errors, with different visual vision. So it's very hard to do a prospective study in adult amblyopes. You can only have a case series or etc. But I think it's worthwhile looking into it. What do you say, Virender? I think it's definitely worth a study.
Definitely, fully agree with you. It's worth a study, and with proper planning, taking care of what is the cause of amblyopia, that would be very good.
So, Dr. Virender,
coming back to what,
carry on, please.
What you were trying to ask, what is the current recommendation for management of amyotrophic amblyopia? So I think the landmark study, which is there by the pediatric group, holds very well, and in our experience also, appropriate refractive correction and adaptation shows very good improvement in over 85 to 90% of patients over a period of 1 year, and we have seen majority of them improve. If during the course of the treatment one eye improves better than the other eye and there is significant difference between two eyes, monocular patching might be offered as one of the therapies that does work. When it doesn't improve in patients, I think we should explore whether there is a coexisting another pathology. For example, child could be having an occult macular dystrophy. They could be having a subclinical myopic maculopathy, and other small teres pallor might be there. The child could have had a subclinical optic neuritis. These are some of the 3 important things that we observe in our patients who don't improve with ametropic amblyopia.
So I have one more question, is that when you look at a strabismic amblyopia, so what are the cases where you would not offer these therapies? So is there that if the angle of squint is too large or something, where the amblyopia therapy would not be given? The binocular therapies, I would say, not the occlusion, but the binocular therapy.
I think maybe at this point of time, I may not be able to answer it so much because we have not tried so much, but I think it does require that the patient who is having a pretty large heterotropia with constant squint, it might be difficult to offer the binocular therapy to the best possible extent. That's one thing. And definitely if there is dense amblyopia already set in with eccentric fixation, that would be another thought. Dr. Meenakshi.
I just wanted to add, as far as I know, there is something called VR Remed, which is the virtual reality. As far as I know, that's the only therapy today which offers a way to offset the angle and offer the therapy. So that's the only thing available. But I don't have any personal experience, but I know that it is possible to give treatment in strabismic amblyopes with the Remed, the virtual reality.
So I think we are running short of time. So I would just request all the panelists to just sum up their comments about the article and the amblyopia therapy. Ma'am, you?
Okay, I will. I think the article has been summed up really well and quite a bit. I just wanted to add one line in continuation of this ametropic amblyopia that we were talking about. Even today, people undercorrect astigmatism, people undercorrect myopia, and sometimes these are factors that can definitely be, avoided, can be addressed when you treat bilateral or ametropic amblyopia. Just always ensure that you are given the correct, appropriate, full refractive correction.
Dr. Virender, your final take on amblyopia therapy, whatever you could.
Yeah, I would just like to say that amblyopia is a diagnosis of exclusion. So at the offset, you make 100% effort to make sure it is amblyopia and it is nothing else. Make sure that we are not missing other pathologies. Check color vision at presentation also. And then you start with one therapy, whatever you are comfortable. You can go on to add other therapies. You can do a sequentially aggressive amblyopia therapy. So that does work in majority of patients if your diagnosis was good. Compliance is the thing you need to work. So have patience and persistence to give the appropriate therapy. Thank you.
And so similar to the occlusion therapy, where we give more hours of occlusion therapy in severe amblyopia, is there any protocols followed for this binocular vision therapy? So
I think it should be, but maybe Oli would be best to tell his experience with that, increasing the number of binocular therapy.
Yes.
Yeah.
Yes. I think in adult patient, yes, as we are working on the binocular neural pathways, primarily in adult amyloids, there are neurosciences, lot of is coming up with talking about neuroplasticity of binocular neurons. I think that is towards more appropriate compared to the monocular approach, and it does give you better results. So far, with the very small data subset, we do see significant improvement happening in adult population with this approach. Maybe we just because we do see a lot of strabismic amblyopes. As the binocular approach, it is not going to interfere a lot, because when both the eyes are open and patient is strabismic in nature, then you are not going to stimulate the fovea of the strabismic eye, and that may land up in giving extrafoveal point as a treatment, which can be landed up into more complication rather than a gain.
So are there any other questions from the panelists?
Can I just make a comment, please?
Yeah, Dr. Samir.
Okay. I think amblyopia, we misunderstand that it ends at the occipital cortex. It is a global brain problem. It's not only the visual pathway is affected to the striate cortex, it's the extrastriate area, the frontal eye field, the prefrontal cortex. These are all affected in an amblyopic eye. And they are being dominated by the good eye neural connections. And unless we block the input from the good eye, you cannot achieve a 6/6 vision in the amblyopic eye with these binocular therapies. Binocular therapies, they are very important for ametropic amblyopia, but not for strabismic, not for eccentric fixation, not for long, deep, severe amblyops. It won't work. It's a waste of time. So rather than you just switch on to full-time patching, tell the patient, you give me your 2 eyes for 2 months, and I'll return you the good eyes with the 6/6 vision in both eyes. In 2 months, full-time patching, it gives you excellent vision, 6/6, 2 to 3 months. All you have to do is how you motivate them, and there you get the compliance.
Thank you, Dr. Samira. I think with this, we are already short of time. Vaishal, we can't hear you.
You can have the discussion.
Yeah, I just wanted a last question. Dr. Santhan Gopal has proposed a different amblyopic approach from up to down, unlike the down to up stimulation of the visual cortex. Ma'am, Meenakshi ma'am and Virendra sir, your inputs.
Dr. Santhan's a good friend, so I can't critique anything as yet. But I will say that I'm waiting to see more data. Anecdotally, I know of patients and I know of practitioners who are very impressed with the improvement. I know of, what I don't know is how sustained is the improvement. And so a lot of anecdotal evidence is there that it works, and it's a very different mechanism. But as we are clinicians, scientists, we want to see data. So I'm waiting for that. Thank you.
Virendra sir, your inputs.
Yeah, same here. We need to, the mechanism seems very promising, but we need to have more robust studies analyzing the same way like we discussed this aspect.
Fine. Because as Samira ma'am said, stimulating the other peristriate cortex, that's what Santhan Gopal sir has done. So he's stimulating the peristriate cortex, and then the inputs come onto the occipital cortex.
Yeah, exactly. The mechanism proposed mechanism is very elegant, and it's very showing very good results in the examples he shares. But we need to have more solid data with controls.
Absolutely.
Sabyasachi wants to say something.
So I basically wanted to say that, you know, studies go through the journal reviewing system and through the sieve that we've put, you know, and they actually make it to journals. But if you look at, you know, studies from this device, I think there are 3 studies now. Most of them would not really, you know, should not have probably made it to the journals. Let me put it that way. And you know, so the readers need to understand that you know, just reading the abstract and the conclusion of the abstract, that's what most people do. You know, we'll look at the title and then we'll just look at the conclusion of the abstract, and that's about it. So that, you know, the sort of the biggest take-home message from all this discussion is don't do that. Try and read the full text. Try and make sense of the methodology. So Meenakshi ma'am, first thing she said and first thing she tells her residents is look at the methodology. And so, you know, sort of, I think if the residents can go home with that message, I think a job is half done for a journal.
Great. Very important pearls of wisdom by Dr. Swaminathan ma'am, Meenakshi ma'am, and Virendra also, and Samira. Very nicely put up all the points.
Thank you.
Thank you.
Thanks very much.
Yeah, we'll have
Rajesh sir, vote of thanks.
Yeah.
Rajesh.
We have entered people to show their video.
Yeah,
and the gallery view shot also, please. Yeah. Anmol.
Sorry, sir, I missed.
We have a gallery view shot first, and if you have the video play, otherwise we have the thanks to you.
Sure, sir, sure. Just allow me a few seconds to take the gallery view and then followed by after that the video.
Yeah, please. Yeah, I think Rajesh.
Yeah, the crux of today's discussion is amblyopia treatment using Occlu-tab provides a better improvement in visual acuity than an eye patch. That will address compliance related to amblyopia. However, still a long way to accept this therapy. Thank you, Meenakshi Madam, Dr. Samira, Dr. Virender, Dr. Sabyasachi for critically analyzing and dissecting the article. Really valuable inputs and perfect example of how to read a research paper. I hope residents will definitely benefit from today's journal club. I thank Dr. Anisha for presenting today's topic. You really presented well, Anisha. Thanks to Mr. Olilula for highlighting vision therapy in amblyopia. Many thanks to coordinators of today's journal club, Dr. Priyanka, Dr. Parul, and Dr. Vaishal. I'm also thankful to office bearers of BOA. Special thanks to Lahani sir, MOS advisor, for joining today's journal club. I'm also thankful to all those who have joined on the virtual platform for today's journal club. Thanks to Entor for the technical support. Thank you all.
I'll just ask Dr. Sumit Lane to have put the final thanks word.
I think Sumit has left.
He said
good evening, everyone. Sir, I'm here.
Yeah. Yeah, Sumit.
Yes, sir. So, thank you everyone on behalf of BOA, and thank you Vaishal sir and Parul ma'am for getting this ahead, and all our respected dignitaries, Meenakshi ma'am, Samira ma'am, our own Sen Gupta sir, everyone for being here and enlightening this topic. And yes, Mr. Oli, who has developed this software and working very hard on improvising it and not only developing and leaving it like that only. So as it is discussed that there is a long way to go, and of course a prospective study is needed to actually prove the outcome. So we are also looking into it, and soon we will also be coming with the study for a prospective outcome of Binocs. Thank you everyone for being here and spending your evening with us. Thank you, Vaishal sir.
Thank you, everyone.
Thank you.
Perfect.
Yeah.
Thanks very much.
It was a very nice discussion. Huh? Samira, you also put in a lot of inputs. Very nicely done. Of course, Meenakshi madam and Virendra also added, and Sabyasachi as usual, a critical statistic analysis. Maja aa gaya. Can we have the recording off, please?